I will now demonstrate a sphenoidotomy. The sphenoidotomy can be performed before completing the ethmoidectomy or after completing the posterior ethmoidectomy. Here you can see that we are removing the last partitions of the posterior ethmoid cell, and we can visualize the rostrum of the sphenoid in the distance. The superior turbinate is the most important landmark when performing a sphenoidotomy, as the natural os is always located medial to the superior turbinate. Here we can see the natural os, which is typically in humans covered by a thin membrane. Using a freer, we can sharply enter the sphenoid sinus and then widen it with the freer forceps. This allows maximal preservation of the superior turbinate and in turn respect for olfaction. We can now resect the inferior part of the superior turbinate at its insertion into the posterior face and lateral wall. Once this is performed, an instrument such as a kerrison or a 45 true cut can be used to widen the sphenoidotomy. It is safe to widen it first superiorly and medially, as the vital structures of the optic nerve and carotid artery exist on the lateral wall. We can then extend it inferiorly and laterally in an L shape. Once this has been performed, we can clearly visualize the sphenoid sinus and can use a cutting instrument to resect the remainder of the rostrum. Here we can see a 45 true cut carefully dissecting away the front face of the sphenoid sinus. It is important not to put a powered instrument, or any other instrument for that matter, deep into the sinus, as if there is a dehiscence of the optic or carotid nerve, injury can occur. Here we can see the optic nerve coming into view. The carotid artery sits lower and more lateral, and there is an opticocarotid recess between the two. Once this has been performed, we can then complete the finesse touches of the ethmoidectomy. It is important to remove the basal lamella up to the superior and the middle turbinate, as disease can often hide here and increase the recurrence of polyposis. Here you can see that we are using a double-ended ball probe to gently fracture the basal lamella of the middle turbinate anteriorly. A sharp instrument that can then be used to resect this thin partition. Here we can visualize a cell which could harbor disease in a patient with chronic rhinosinusitis. We are now opening the cell completely and visualizing the superior turbinate medially and the skull base superiorly. A microdebrider or a 45-degree scope can then be used to visualize the entire skull base, and a microdebrider can be used to remove the remaining soft tissue. Here we can see that we can safely debride the lateral aspect of the superior turbinate, as olfaction is located on the medial aspect. Caution needs to be exerted here to avoid stripping of mucosa over the lamina papyracea and the skull base. By using the microdebrider in a quick motion with short strokes, mucosal stripping can be visualized. Here we can see the skull base superiorly, the lamina papyracea medially, and we're using the microdebrider on forward mode to remove these partitions by a quick drilling motion. Once this has been performed, we can then address the final partitions along the roof of the ethmoid sinus on the way to the frontal sinus. This is best done with a 45-degree scope. At this stage, we are simply tidying up any bits of the soft tissue before we turn our attention to those ethmoid partitions that I was speaking about before. Here we are changing to either a 30 or a 45-degree scope and using a probe to navigate behind the partitions and fracture them anteriorly. Note the probe is not pushing superiorly at all. It's safest to approach these remaining partitions by navigating behind them rather than pushing through them. The partitions are fractured forward, and they can then be used with a combination of grasping instruments or a microdebrider. Here we can see that we are using a 45 Blakesley to remove the bone from the partitions, and the soft tissue will be removed with the microdebrider. Generally, if you remove as many of these partitions as possible, you're likely to get a more complete clearance and a better outcome for the patient. As these frontal recess partitions can narrow the frontal recess, here we can visualize the anterior ethmoid artery as it courses along the skull base in a postero to anteromedial direction. A microdebrider can then be used to remove the remaining soft tissue and maximize the opening of the frontal sinus proper. Here we can visualize the entire skull base from the frontal sinus right back to the sphenoid sinus.